We move to our next session, a symposium on recent advances. For this, our chairpersons are Dr. Manoj Srivastava, Dr. Prakash Sancheti, and Dr. Anupam Singh. I request all to come on to the dais. I request Dr. Gaurav Bhaduri to please chair this session. The first speaker for this symposium is Dr. Ashutosh Mishra. He will be speaking on biomarkers for early detection of end organ damage in diabetes patients.
Believe me, in the next 12 minutes, you will going to realize that you are missing something. So let's discuss a case. Here is Anita. She is visiting my clinic regularly. Her HbA1c was 7.8, and one fine day he landed in the OPD. She landed in the OPD with the blindness. What was her fault? Her HbA1c was at 7.8, well controlled. Still, she lost the vision. That is the story which is occurring day by day in our clinical practice. Somebody is losing his kidneys, somebody is losing her sight, somebody is suffering from heart attack or stroke day in and day out, and still we are sticking to the old traditional thing, not innovating, not trying to correct ourselves. So we must analyze the traditional approach to modify the things. So you all agree that HbA1c is a clumsy knife. It is a reliable thing, but it is slow. Like in the old age, in the war, there used to be elephants. They were reliable, but they are having important limitation of slow motion. While the gorilla war and the horse army used to fight and win the battle. If you combine this HbA1c with 1,5 Ag or fructosamine, you can have an idea of glycemic control with blood fluctuation and oxidative stress, and that is one thing which can be corrected. What about other things? The other biomarkers can also be combined to have a good impact on treatment of diabetes. What are those? Those can be cysteine-C, those can be GDF15, other proteomics, simple proteomics like lactate, urine lactate level, blood lactate level. They are lying there in your clinic. It is easily accessible, but we are not modifying our approach. Urine lactate can prevent many kidney disease. Blood lactate can prevent complication. That is the thing. So, what about the speciality of these biomarkers in India? If you look at in Indian context, you will find that in India, actually, the people are having lower BMI and they are having increased lifetime chances for the complication. And they have strong genetic and environmental factor. So we need to have a different approach, different traditional approach apart from the HbA1c. So what are causing the problem in case of Indian population? Here the oxidative stress is there, AGE, inflammation and protein kinase C activation pathways are there. So if you look at the oxidative damage, there is more and more generation of ROS and there is decreased defense against it. Apart from this, there are markers which are raised for the DNA damage, and that is 8-OH-DG and MDA. These are very, very important. You will listen this thing again and again. The 8-OH-DG and MDA, and this can be an important DNA damage marker, and this can be done very easily in clinical practice. So this is the pathophysiology, how the chronic complication occurs in the background of diabetes. So early intervention can prevent the damage. And this reactive oxygen species is causing damage, but important point is acting differently in different tissues. This is very, very important. The pathophysiology is not same. It is different in different tissues. Okay. What about the Warburg effect? This is the main pathophysiological abnormality where your body cell is relying on glycolysis pathway, anaerobic pathway in presence of oxygen. Even if there is sufficient amount of oxygen is there, body is relying on the glycolysis and lactate level is increased, the intermediate metabolites are increased, leading to the mitochondrial dysfunction. And these mitochondrial dysfunctions are very, very important hallmark for the pathophysiology of the diabetes. So apart from this, there can be a carbonyl stress. What is this carbonyl stress? This is excess production of aldehyde and ketones. These aldehydes and ketones are like sticky molecule. They stick to protein together, leading to vascular stiffness, leading to the atherosclerosis and inflammation. Apart from this, various free fatty acids are converted into different metabolites, and once this pathway is saturated, they are converted into sphingolipids. These sphingolipids are active biomolecules leading to the complication. If you are able to measure this ceramide, the active bioactive sphingolipids, you can predict complication, and ignoring this may cause severe damage. So apart from this, there can be a genetic prototype like the genetic prototype of SMDP1 that is very prevalent in Indian population. If this type of genetic analysis can be done, this will lead to more and more recognition of these people, and you can start early statin therapy, and you can have a better LDL target in this subgroup of population. So ceramide dysregulation is very, very important, not only in terms of diagnosis, but also the amount of statin, the high dose statin, or how early you should start the therapy, like lesser than 30 years. If you want to start statin, this can be a guidance in the therapy. Apart from this AGE molecule, these are very, very important thing, the sticky protein, but everybody reads about these AGE in the complication of diabetes. But what is the implication? Many people ask, this is pathophysiology part, what is the implication? You can have low AGE diet. So what is this low AGE diet? The AGE is a molecule which fuses to protein. So if your diet has propensity to fuse to protein, like high fried, high fat, grilled diet, these diets are high AGE diet. Vegetables, low cooked, steamed boiled is low AGE diet. So low AGE diet and AGE breakers can be adopted in our clinical practice. Apart from this, the protein kinase C activation is also very, very important, and this will lead to microvascular complication, and knowing this pathway can be a very important thing in terms of the pathophysiology of diabetic retinopathy. Why I am saying diabetic retinopathy? In diabetic retinopathy, vascular endothelial growth factor level goes up, and in a pre-diabetes patient, if the vascular endothelial growth factor ratio is increased, then these people are going to develop diabetic retinopathy very fast. So inflammation is very, very important. We have heard of Jupiter trial where HSCRP was one of the targets for increasing the dose of statin independent of LDL. Similarly, you can have a trial focusing on anti-proBNP being one of the targets to increase the statin. Similarly, you can have a trial to different microRNA having one of the target to increase the statin. So there can be a different way of giving the therapy. Apart from this, GDF15 can also be one of the target and one of the explanation to increase the statin therapy. So that's how we can have a personalized therapy in the diabetes. So inflammation is very, very important. Many people think that retinopathy can be prevented only with the help of the diabetes fundus examination. But if the cysteine C level is high, if the proteomics levels are high, if you have machine learning of 3 to 4 markers, then in this subgroup of patient, diabetic retinopathy can be high and they can be prevented. Apart from this, the podocyte dysfunction can also be diagnosed early with the help of different biomarkers like the nephrin, podoskin. All these molecules can be used as one of the specific markers of the therapy. Like if your patient is having high urinary lactate and nephrin level, you can start SGLT2 inhibitor right from the beginning to prevent the damage. That is the beauty of the modern day therapy, and if the microRNA can be combined with the multiplex PCR, which is very much possible nowadays in our clinical practice, this can further improve the chances of the prevention of diabetic nephropathy. So here you can see cysteine C, multiple markers like creatinine, cysteine C, albuminuria, microRNA can prevent diabetes complication. Apart from this, if you look at the cardiac disease, these are very important complications for the diabetic mortality. And if the IL-6 level, hsCRP, NT-proBNP, angiopoietin, these are high, you can upregulate the statin. One of the important molecule which I want to emphasize is GDF15. I will request all of you to go and study the GDF15. What is the implication of this GDF15? This is one of the important biomarker to diagnose diabetes early and all metabolic diseases, stroke, heart attack, NFLD. If you look at the common thing is GDF15. Not only the GDF15, if the GDF15 is way high, like more than 2000 picogram per liter, then metformin is not going to work. So you should remove metformin from your therapy. If the GDF15 is more than 2000, you can give GLP-1 and SGLT2 inhibitor. So that is the beauty of biomarker. You can stratify your therapy accordingly. So biomarkers are very important in terms of the diagnosis of diabetic neuropathy also, and here this 8-OH-DG is important. It can diagnose diabetic retinopathy, it can diagnose the diabetic neuropathy very early stage. Why I have said retinopathy? Because in retinopathy, most early changes is in the neuron. So neuronal damage is the hallmark, early neuronal damage. So here for the neuropathy and retinopathy, both this 6-OHD is important. If you want to diagnose cardiac autonomic neuropathy, which most of the time missed, can be diagnosed with the catecholaminergic ratio. So that is one thing we should take care of. What about these microRNA? These are the beautiful things in the diagnosis as well as the treatment specification of the diabetes. And here you can see that if you have profile of different microRNA, which is easily available in the multiplex PCR, which can be established in your clinic with a good laboratory, you can have a microRNA data to diagnose the thing and to give the treatment. Suppose your microRNA 543 is high and HbA1c is 9. Don't give metformin. Give insulin, because these patients are non-metformin responders. If your microRNA 129, microRNA 126 is high, give SGLT2 inhibitor right from the beginning. That is the beauty about these molecules. So this is a fantastic new area which is developing up, and the metabolomics like the lactate, the glutamate, these are very, very important. You can have a lactate test in your lab. Now the blood lactate is available in form of a glucometer. You have a glucometer. Likewise, you can have a lactate meter right there in your OPD. Suppose your patient is coming with good glycemic control and blood lactate level is high. This is the patient who is going to develop complication very, fast. This requires fluid. This requires aggressive therapy independent of LDL, independent of HSCRP, independent of your AS3 What else you want? This is the era where metabolimics can be accommodated as one of the target for the therapy. Look at the TMAO level. These are very, very important metabolites. If the TMAO, blood TMAO level is high, then cardiac risk is high. Your blood microbiota is altered. So you have to give a therapy to altered blood microbiota. And if TMAO level is high, give low TMAO diet and modify the cardiac risk very, very aggressively. So this is the message. So metabolimics are very important, and now this is becoming one of the important way to treat diabetes. Important thing is branch chain amino acid. If the branch chain amino acids are high, then the chances of insulin resistance and complications are high. Cysteine C, again, this is very, very important molecule, and you can have a cysteine C in your laboratory. It is ELISA based test, very simple test. It can be done in your clinic, like the thyroid test, it can also be done. But it gives multiple information in terms of complication as well as treatment of diabetes. Similarly, the genetics, if the genetic facilities are available, they can be of helpful, but they are expensive. So in resource limited countries like India, the biomarkers like metabolomics and the other biomarkers are more suitable than the genetic marker. Machine learning approach where you modify the things and have a wisdom of multiple biomarkers will going to solve the problem. Okay, what about the gut microbiota? Gut microbiota profiling, as I am saying, it is very, very important. Every person who is visiting into the metabolic clinic must go with this gut microbiota profiling. But now the gut microbiota profiling is very, very expensive, costing around 10,000 rupees. What is the solution? The solution is multiplex PCR. The multiplex PCR can identify 3 to 4 important gut microbiota, and that can be done below 3,000 rupees market price. So this can be one of the way in the future, and gut microbiota profiling is important. So I will request all of you to adopt 5-step approach: annual microRNA level, or having cysteine C, HSCRP, GD of 15 based approach, have vascular endothelial growth factor and PEGD ratio, and accordingly you can stratify your patient and treat your patient. If your patient is at risk, start SGLT2 inhibitor, green tea, butyrate right from the beginning, and if the risk is high, probably combine SGLT2 inhibitor with GLP-1 right from the beginning along with the high dose of statin. So ladies and gentlemen, last slide. As we are having war with Pakistan, there was important strategy which our Indian forces have made. So I recommend 4 things. First, screen earlier. Think multimodal. Never rely on one thing. Like in war, we have been proactive. We are multimodal. Our defense system was multimodal. Igla, Akas, the S-400 and the anti-aircraft gun are combined together, not relying only on S-400. That is the beauty. Never rely on one thing. Have a multimodal approach. Have a personalized approach. Don't shoot drone with the SG-400, S-400. For the drone, the IL-17 guns are suitable one. So you have to choose the therapy. Like metformin blanket #1 approach is not a good approach. And act promptly. Never waste time. Always be proactive. So if you want to prevent diabetes, become a hero like our Dr. Patni. So you will be hero like Dr. Patni, and you will give 15 more years of life to diabetes patient. Thank you so much. Finished on time.
Yeah, thank you for the very nice lecture. So we learned a lot about the newer biomarkers that we have. So any questions from the audience?
What do you recommend in clinical practice?
Yeah, that's what I was expecting, and sir is very kind to me to put a question like this. Sometimes with pathophysiological talk like this, it is very important to go with take-home message. This is very, very important. First thing, I will recommend all of you to have at least the blood lactate glucometer, or ask your laboratory to have a blood lactate level. One thing. Another important thing is start utilizing anti-pro-BNP or BNP as an important biomarker along with HSCRP. So that is available most of the time. Another important thing is utilize cysteine C as one of the important biomarker to have stratification of complication. Like which patient is more prone for retinopathy and nephropathy. If the cysteine C level is high, more than 1.14 picogram per deciliter, then the patient is a different patient. It has more propensity for the retinopathy and nephropathy. You have to be very, very aggressive in this subgroup of patients. And last one, if you are having facility for multiplex PCR, ask your facility to have these microRNA, at least 3 important microRNAs to be done. One is microRNA 129, another is microRNA 21, and third is microRNA 543. Why I have named these 3? Because microRNA 543, if it is high and HbA1c is 9, your traditional medicine is not going to work. Give insulin. Otherwise, patient, you are going to lose your patient. And metformin is certainly not going to work. If microRNA 129 is high, inflammation is the main driver for the pathophysiology of diabetes. Give anti-inflammatory drugs like SGLT2 inhibitor and GLP-1. And if microRNA 120, only 29 is high, you are probably dealing with a patient who is having early beta cell failure. So this is the thing. At least I want you people to be sensitized on this part so that you go home with one particular thing and start adopting at least one biomarker. And if you want to adopt one biomarker, GDF15 is also one of the important ones. If GDF15 level is too high, like 2000 picogram per deciliter, metformin is not going to work. What is GDF15? GDF15 is a molecule which is high in all cardiometabolic illnesses. Stroke, nephropathy, retinopathy, obesity, diabetes, cardiac disease. GDF15 is common. Okay? If the GDF15 is way high, metformin is not going to work. Remove metformin. If GDF15 is way high, SGLT2 inhibitor and GLP-1 can be used. If the GDF15 is one of the level, say 500, start metformin. Look at the repeat GDF15. Suppose it is increased. It is increased, then the metformin is going to work. Metformin has this effect by increasing GDF15. So if the GDF15 is increasing, metformin is going to work in your body. So that are the few things which I want to emphasize, and you will see in next 3 to 5 years all these things will come into the clinical practice, and it will help in stratifying the diabetes patient. The whole idea is to stratify diabetes patient and not to have a blanket approach rather than personalized approach.
But is it related to the insulin resistance anyhow?
Yeah, it is. Some of the microRNA is related to the insulin.
GDF15?
GDF15, yes, it is. Actually, what is GDF15? GDF15 is a metabolic biomarker. Once it is increased, then you know that most of the time inflammation is very, very high, and it is actually causing insulin resistance. It is increasing free fatty acid. It is actually causing appetite to increase.
Yes, but once you cut down the glucotoxic level, then it can revert.
but unfortunately it doesn't. In subgroup of patient where if you control blood glucose by sulfonylurea, GDF-15 may not go down.
No, not with the sulfonylurea, but with the even with the insulin, if the glucotoxic phase.
Yeah. So,
So what I want to just convey, sir, just a minute. If you decrease GDF-15 by SGLT2, then probably it will have a cardioprotective effect. But if you decrease GDF-15 by any other mean like insulin or something, you are not probably reducing the cardiovascular risk disproportionate of the glycemic control. Glycemic control will have its effect, but you want pleiotropic effect. That pleiotropic effect will not be there. That's what I want to say.
Sir, one last question from the audience. Professor Dr. Sharma from Calcutta.
Yeah.
Nice presentation, sir. A lot of new things it has been for us who are practicing the diabetes and these things. So a lot of packages is nowadays available, just like renal package, cardiac package and these things. So in diabetes, those who are the diabetologists and practicing diabetes, nowadays on the affluent society and these things, they are having a no burden for the monetary things and these things. So we are usually sending the patient fasting blood sugar, HbA1c, BP as a package and these things. So in the basic investigations which you have been suggested and these things, if we include all these things in a package, suppose advanced diabetic package or diabetes package 1, 2, 3.
Yeah.
So if these things and what you have been suggested, how much it will cost at this moment in Indian market?
Very good question. And that's how I think in my clinical practice.
Yes.
I have a genetics lab. Now we are starting this genetic lab, and I have asked the multiplex PCR people to customly design the things according to the prevention and the stratification of diabetes. If you look at the commercial thing and you do all these things in a random manner, it will cost a lot. But if you look at the GDF-15 kit, it is costing nearly 250-300 rupees per ELISA test. So if it is doing, it has been done regularly. People are doing more and more to substantiate the opposite with the research, and we have to substantiate all these things, because anything which can be done regularly will only be substantiated. So if you have multiple markers and it is doing repeatedly with the ELISA method, with the multiplex PCR, the cost can be reduced up to the 5,000 to the 7,000 with the sizable number of 3-4 biomarkers and 2-3 microRNA, all combined together into a multi-modal approach. That's what I want, and that's I want to thank Dr. Patni, who has given me this topic, and I have adopted in my clinic like this.
Sir, so because of shortage of time, so if anyone has any question, please ask me. Right? So the next speaker is Dr. K.K. Tripathi, sir. He needs no introduction. His topic is going to be integrating novel therapies and personalized approaches in advanced TKT. So you can put his introductory slides also.
Thanks to Dr. Ashutosh for bringing up the topic, and thanks to Dr. Patni for giving me this topic. We live in this country with two different extremes. Dr. Mani, N.K. Mani at Chennai, a celebrity in renal medicine, he started Chennai program in the community with 50 paisa glycemic down. Adult fairness is less than that. Another 20-25 paisa at that time, used in community, not with the patient, and the incidence of chronic kidney disease was reduced by 37%. This is one extreme. Another, we have the biomarkers, we have molecular medicine, we have precision medicine, which could be, I don't know how costly it will be. My next house has Jan Aushadhi, and my 70-80% patients insist upon that you write me a medicine which is available in the Jan Aushadhi. Don't write any other prescription, otherwise I will not be able to buy it. So we live in a different society. However, academic medicine, when we take 100 steps more, one step, we go back to 99 steps back. During our career, early 70s, when we started the fraud, at that time, kidney biopsy was one of the only way to look at the kidney pathology or his behavior. In between it was dropped. Now again in precision medicine this is wrong. And this is the reason because in tertiary institution where most of you practice, when a patient comes, hardly anything can be done, but for getting him on the transplant or a dialysis program, very high treatment, difficult to control hypertension, dyslipidemia, one coronary or two coronary event, patient could have a stroke. And at the primary care level, when the patient comes with the diabetes, hardly any sensation. He may take, he may not take. But this is a serious microvascular disorder. And 40% individual with diabetes have it, and the percentage is increasing. Walk in any dialysis unit, this is more than 31.3%, and the stage renal failure could be reaching very, very high. Some of my slides would be the same what Dr. Ashutosh presented, but this is the time when ultimately we have to decide where to intervene, how to do early diagnosis, and make a precision medicine. The 5-year survival on maintenance dialysis, which is easily available now in Tamil Nadu, Uttar Pradesh also, maybe Bangalore also. This is available at almost every district hospital, and with Ayushman card, people are getting it. But it is less than 25% worse than any cancer. And this active clinical trial testing therapeutic agents slow the progression of DKD, but they have their own limitation. Therefore, now the precision medicine starts with doing a renal biopsy, which is a technically skilled job, needs a good pathologist, need a good lab. And if you send this tissue to Dr. Lal Path lab, this would cost something like 10 to 15,000 rupees. So this is one of the limitations for the basic histology, and with omics and proteomics, there is sub-classification, and you can achieve targeted therapeutics. If you try to make a precision medicine in this group of patients with diabetes, at my top, you look at the graph with precision medicine, you could have a good sustainable glomerular filtration rate, right up to 60 to 45. If you don't, it deteriorates very quickly. So this is called the Precision Medicine Project, in which based on clinical presentation and the histology, traditional as well as digital pathology, with the help of omics, imaging, ultimately you decide the diagnosis and develop a mechanism-based disease subtype. There are phenotype, could be molecular, could be clinical, with biomarker and candidate selection, testing, ultimately we select a drug, what Ashutosh was talking, the precise drug. You could look at the autoimmunity. There are the clinical ways to look at the subclassifying. There could be GADA positive, there could be low BMI, there could be mild obesity phenotype, there could be age-related, insulin-related phenotype, and sex-related phenotype. So based on all these parameters, the histology, the immunobiochemistry, the immunohistology, ultimately going to the proteomics, one can decide, and then look at the ontology and data integration. What we were talking this morning in this very hall about the artificial intelligence-based diagnosis to select a particular drug. This is the integrated functional kidney map based on the input from imaging, three-dimensional imaging, cytometry, multiplex immunofluorescence technique, micro-region kidney microarray, and ultimately single cell, single nucleus, and then the phenotype. So this is a complex situation in which you look at the subject, look at the specimen, look at the omics, look at the data, and then you make a diagnosis, which is so difficult. But you can rely on biomarkers. And there are two different biomarkers from the different sources. From the earlier stage when patient comes to the primary care physician or first contact physician, then look at the KIM, TNFR, histopathology biomarker, and look at the thickening of basal membrane, which is done by electron microscopy and mesangial expansion. You can add 15 to 20 years life. Early diagnosis, early treatment, prevention. Later stage would be microalbuminuria, slow GFR, proteinuria, KW nodules, and by the time it happens to any tertiary care institution or the corporate hospital, you can hardly give 3 to 5 years of life. And the maximum follow-up of these patients on the transplant program is hardly 5 years, otherwise patient goes into rejection or in a chronic kidney stage. So these are the based on biomarkers, BRCA1 and 16 genes, 4 were specifically related to glomerular basement membrane and collagen, and there are genome-wide association. And it's a huge number, and they have not been validated. And clinically they have not been translated even. We do not have yet data, but these are the research projects which are in pipeline, and where we decide, and what Ashutosh was talking about, the 17 proteomics, which is pro-inflammatory tumor necrosis factor, on the KIM1, and then there are the factors related to CKD273 classifier, which is another biomarker which has been now been added in the diagnosis of chronic kidney disease. Then novel therapeutics precision how to formulate based on the apolipoprotein L1, antiphospholipase A2, and NTPL2R. This is one of the, because most of the kidney patients with diabetes or diabetic patients going into diabetic kidney disease, they don't respond. And this is to differentiate between a primary glomerular disease or a diabetic kidney disease based on the NTPLRA2, and they decide to treat. The old one, which we have left long about 30-40 years back, the DDID gene, the insertion deletion gene, in relation to the ACE inhibitor. And some of you would be surprised why ACE inhibitors, ARB, they respond much better in a group of patients, others they do not respond. And all of this is the reason about the gene distribution. And they would not be responding if patient is positive for the ACE gene. This is the adjusted odd ratio accord, and the 2 trials have been done, and I was talking to this. Look at the difference. Hardly you get any viable, clinical, sustainable difference looking at this particular chart. In spite of biomarker studies, still when you select a molecule, you may not get a very satisfactory response when it comes to therapeutics. So the last decade seen progress of understanding of genetic basis, and one of the important contribution has come by what Dr. Vishwanath from Chennai has done about phenotype classification. And we now understand that the body, which is a variety, and I'll come in a moment to those are some of the observations which has changed the concept on selecting the molecule. 14 genetic variants have been now classified under Modi group. And there are the drugs like GLP-1, RA, as well as DPP-4 inhibitor, they change the course. And renal and cardiovascular prognosis of these patients with Modi H, the polymorphism is similar when compared to patient type 1, type 2. Depending on this graph, we will now come to some of the clinically relevant information. These are the South Asian phenotype in diabetic kidney disease. And what is important in this particular group? Regression to albuminuria, rapid GFR decline, absence of proteinuria or albuminuria, they would dictate the various phenotype. This is again Dr. Mohan Group publication where they have said that CI are combined insulin resistance and deficiency diabetic. These are the patients who have got highest hazard for kidney disease. And you can make a diagnosis. It is not very difficult to make a diagnosis of these different phenotypes. The nephropathy and CKD, look at the numbers, it is 6.4 to 6.3, much higher in the patient of SID and MARD rather than the retinopathy, which is seen in the lesser number. This is another phenotype which has been added. This is from the NHS Trust Hospital, London, UK, where they have tried to identify 4 different phenotypes, which is called cardiac phenotype, cardiovascular phenotype, microvascular complication with advanced CKD, phenotype 3 which is advanced CKD with less anemia, low body weight, and phenotype 4 which has got lipid abnormality, younger patient, less severe kidney disease. How it has changed, I was talking to this particular slide. The time after doing a kidney biopsy, which is not usually done, only done by expert nephrologists. But this has changed the scenario. Look at the top. Number of months, and on my left side, you look at the black, which is depending upon the phenotype. It has changed the course of renal survival as well as the graft survival. So polygenic recessive score based on 35 SNP on beta cell dysfunction. This is more severe in MARD and SIRT rather than majority of the diabetes. And 20 SNP, which is insulin resistance, decide the heart failure. So there are two different categories based on these studies which would decide whether this patient is going for the cardiac complication early or progression of chronic kidney disease. The majority of patients who have diabetic kidney disease with albuminuria, there are two different phenotypes. One is albumuric type, another is glomerular type, where there is a fast deterioration of GFR. 46.6% of this population, they expect distinct clinical feature, and that would have a screening, therapeutic and prognosis implication. Another very clinically relevant information is MSLD and patient with proteinuria, without proteinuria. And look at my right hand graph, those patients MFLD with proteinuria had a different prognosis, those without proteinuria had a different prognosis. So massive proteinuria, and here is the relevance of using a molecule, clinically significant to decide whether they would respond to eplerenone or finerenone group of the drugs. Otherwise, they may not respond to it. This is looking at the DKK3 creatinine ratio and to different three groups. Moderate loss of GFR, then ultimately maximum, and then the minimum. And this would decide about the fate of these risk trajectory of these patients who have this particular proteomic DKK3 creatinine ratio, and which is important deciding the treatment plan. Somebody was asking this question in the morning session, which one is better? And look at the different combination, looking at the studies of glucagon, the GLP-1 as well as GLP-2 inhibitors in prospective validation. And depending upon various score changes into, these drugs would respond in a different phenotypic situation. This is the another what he was talking on the nephrin and one of the molecule, and looking at the podocyte phenotype with extracapillary hypercellular. This is extreme pure pathological histopathology based classification where the extracapillary hypercellularity patient had a significant loss of podocyte phenotype and severe food process loss as well as effacement, and they would dictate about the quantum of proteinuria as well as the sclerosis. So you can think of this as a few summary slides, renal protection based on SGLT2 inhibitor, RAS inhibitor, GLP-1, statin, and non-steroidal MRI. And they all would be dictated now based on the various markers as well as the phenotype. You can make a presumptive diagnosis clinically, and you can apply these kidney-based, biopsy-based diagnosis. 4 pillars could be started as disease prevention, could be also started as a therapeutic moderation. Therefore, to conclude, in advanced kidney disease, biomarker identification would help in precision therapy. More than 30 genetic variants for DKD have been now identified. There are tubular like TNFR1, TNFR2 and KIM1. In the gamma-induced urinary proteomic profiling has been successfully applied to predict the 10-year risk of development of DKD. And important to understand the old DD genotype-based inhibitor and antiphospholipid A2 receptor for the diagnosis disease activity. South Asian phenotype have a variable course with the DKD, and we understand now that SID, IRD, and CIRDD have a highest incidence of chronic kidney disease. MEFRD is another proteinuria associated with or without, which is a phenotype that is responsible for the outcome of the kidney disease. With extracapillary hypercellular, what we used to call as crescentic glomerulonephritis, have severe clinical features than patients without it. Vascular damage is closely related to severe podocyte injury as well as hypoxia. And DKK3, which is another new proteomic, has been added in the armamentarium to decide about the progression of the diabetic kidney disease. Thank you very much. Any question? But all said and done, this requires specific precision and a validated lab. Do not jump on the diagnosis because of few proteomic changes, like cystatin C, which was very popular at a time. No study has shown that it is more important than serum creatinine, which is very cheap available. The variation, the validity, the course over the period has not yet major miracle in the treatment.
You want to say something? You want to say?
Thank you, sir, for the very beautiful lecture on this very important topic. Any questions from the audience?
Yes.
How differentiate between non-diabetic and diabetic? And what impact does it have?
Active urinary sediment. Doing a simple test of the urine sample, early morning sample, with what we call liquid kidney biopsy, and if you demonstrate active urinary sediment, this is again 50 years old teaching, and still it is valid today. And if you demonstrate presence of cast, RBC, as well as massive proteinuria, this is dictating that you must go for a biopsy. These are the specific primary glomerular disease, which is a non-diabetic kidney disease.
What impact does it have diabetic kidney disease and non-diabetic kidney disease?
In a non-diabetic kidney disease, diabetic we all know, we have good glycemic control, good control of blood pressure, MRAs, SGLT2 inhibitor, and they would help in the reduction of the proteinuria, hypertension, as well as the rate of the progression. In non-diabetic kidney disease, we are seeing IgA nephropathy, which is 100% manageable. Extracapillary proliferation, again would respond to the immunotherapy. And you are surprised to know that patients even like multiple myeloma. Patient has been coming for diabetes for many days follow-up, not responding to do a kidney biopsy, without lytic lesion, without having well-known protein, much earlier than that, these patients could have myeloma protein in the kidney biopsy. So these are the four treatable, manageable conditions: multiple myeloma, extracapillary proliferative cholestatic glomerulonephritis, IgA nephropathy, and now anti-PLRA. I was talking about the membranous nephropathy. They respond very well, and this is the reason why we still have some of the biomarkers. If it is a tubular biomarker, goes in more favor of the diabetic. If it is a glomerular biomarker, primary kidney disease.
Thank you so much, sir. This is our next speaker.
Thank you.
Dr. Vijay Patni is a full of introduction. I don't mention too much about him. Everybody know about him. His topic is today retinopathy and vision preservation disease. This is our last. Thank you so much, sir.
Thank you, Chairperson, and I'm the last man standing. But I think this is one topic which really impacts the quality of life instantly. So obviously, we need to understand what the vision preservation strategies should be in today's scenario. So I'll be speaking on retinopathy and vision preservation strategy. So first and foremost, we are all aware that it's a significant microvascular complication, which definitely is extremely important. Early awareness is crucial for intervention. And the severity levels might be variable, it might be mild, and then go to severe level where you can use the eye as well. So early detection is a norm, and as I said, it is one such scenario where the quality of life is impacted instantly. The impact is huge. We have 160 million global cases with diabetic retinopathy, and vision-threatening cases may be almost 47 millions. And the leading cause of vision impairment in working age adults. So that's again going to have a huge impact both on the economics financials, as well as the healthcare sectors. Looking into the Lancet study, more than 40,000 participants being screened, where we found out that the prevalence was more than 12% and 4% being visual threatening diabetic retinopathy. And the strongest risk factor was hyperglycemia. So we can relate diabetes, hyperglycemia to the most problematic visual threatening diabetic retinopathy. So this is the pathophysiology, all of you are aware of this. What we all understand, high blood glucose, I try to make it as simple as possible. They do close the tiny blood vessels. The eye attempts to grow new blood vessels, or these new blood vessels are not very well formed, so there will be leakages and all, and that is the reason why we have the eye damage, leading to diabetic retinopathy. And this is what the stages of diabetic retinopathy is, from the molecular stage to the clinical stage. So molecular component could be mild DR, moderate DR, and then it actually manifests when you start witnessing the clinical manifestation of diabetic retinopathy. So now looking into the risk factors and symptoms, the most important risk factor, as we suggested, that it is the poor glycemic control, because data will be showing the DCC trial has clearly showed that aggressive and the beta control has a huge impact on reduction of diabetic retinopathy. And the longer duration of diabetes means a longer chance of you having diabetic retinopathy, hypertension, dyslipidemia, nephropathy, pregnancy, and tobacco use. And symptoms, initially, could be not at all noticeable. And this is whereby all the guidance are telling you when to screen, and type 1 or type 2, and that should be followed to the T. Basically, the screening is most vital, and that should be screened appropriately. So there could be affecting both eyes, blurring of vision, floaters, fluctuations in vision, impaired color vision, dark empty areas in vision, and severe loss obviously when you have the vision loss. So these are the basic screening tests which need to be done for diabetic retinopathy. You should always include the testing the intraocular pressure as well, because that is going to have a huge impact if we have early cataracts in diabetic population and the intraocular pressure is high, then probably you won't be able to take care of the cataract operation as well. So you have to undertake these various screening tests in order to understand how severe the retinopathy is. Now, how do we really differentiate in diabetic retinopathy? You can have a background retinopathy, pre-proliferative retinopathy, proliferative and diabetic macular edema. They all can be actually identified, and which we used to do by the simple use of ophthalmoscope. We don't need a camera always, or an ophthalmologist opinion. All you need to have a practice with the ophthalmoscope. Probably will be to identify most of the stuff like cotton wool or the venous dilatation and sometimes the bleeding as well. But why it is so important when you are trying to look into the eye? Probably you will be able to recognize them early, and the referral becomes easier for you. You have to have that adequate referral at the adequate time. So that is why it's so important that we need to understand what the ophthalmoscope says. So this is the background. I'm just going through the few of those pictures. I don't want to unnecessarily stress you all. I am very happy to see so many people at the end of the conference, almost the end of the conference, sitting for the valedictory to happen. And we will all invite you all on the stage for the valedictory session. Thank you for being there. These are the pre-colored retinopathy. We have the proliferative retinopathy and the macular edema, which can classically be seen out here. And we need to recognize all these, and each one of us can do it. The very simple stuff you can do it in your clinics. So now with the camera aid, you can also diagnose with the help of the AI. You can do it much more easier. You don't have to really do anything. Probably the AI is going to give you the diagnosis. Then at least you can refer the patient adequately and appropriately. This is the macular edema you can see. So now, main strategy, how to prevent the vision loss. So the primary prevention remains the same for all diabetic patients, whether it's for retinopathy or any other complications. But secondary prevention is the goal, and there the glycemic control, the blood pressure control has to be adequate and should be the targets. If you can keep the blood pressure and the glycemic control in a much better way, So probably you can prevent these microvascular complications. But once it is developed, then you have to go for tertiary prevention, whether it's a laser therapy or go for angiogenesis inhibitors. So the tertiary prevention, again, these are the various stuff which we are not supposed to know. That the ophthalmologist obviously will take care of it, whether it's a laser therapy, the angiogenesis inhibitors. But the problem is the drawbacks, which is access to the care. Obviously in Tier 1 city we don't see that. Late disease stage is still very much prominent even in our place. So this is one need to be addressed and taken care of. And then the various molecules which are coming, they do have their own side effects. That has to be also understood basically. But then the single most effective medical management, treatment for diabetic retinopathy still happens to be the glycemic control. So adequate and appropriate glycemic target should be there for each individual. As obviously we need to individualize the therapy, but you should be closer to the target in order to have the best of the, in order to prevent the microvascular complication. And this was the DCCT trial which I was talking about, that if you have a strict control, that will result in the reduced reduction of risk reduction by about 76% and reduce risk of progression by about 54%. So just by having an intensive glycemic control, you can have such good risk reduction, both as far as the prevention is concerned and also by cutting down on the progression. And there is a continuous knowledge and relationship between the risk of retinopathy and the main level of experience, which you can appreciate from this particular graph, that as the HbA1c increases, obviously the risk of retinopathy increases as well. So to conclude what the DCC said way back in 1993, the total lifetime exposure of glycemia was the principal determinant of the risk of retinopathy. So early intervention definitely decreases the risk. There is no level of glycemic control below which a reduction in this does not happen. So a reduction in glycemia means a reduction in the risk of retinopathy. So improved control always reduces the reduction in risk of retinopathy. As I said, blood pressure is another important risk factor which also should be taken into care, because most of the blood pressure people living with diabetes will also have one of these as a comorbid condition. So one need to take care of the blood pressure as well, and also the cholesterol. These are the various studies. They have clearly shown that increased serum lipids will definitely increase the risk of heart accidents and also the vision loss. So that is also important, that we need to take care of the dyslipidemia as well. So these are the research innovation. We need to look into the molecular mechanism, and then there are various imaging techniques which has come in, which can always detect diabetic retinopathy much earlier. Anti-VEGF therapies has undergone generational change, and they are coming day in day out with the newer versions. And ultimately, it has to be personalized treatment in order to have a better kind of outcome. So the clinical implication has to be early detection, systemic disease management, a multidisciplinary collaboration. Do not fear referrals. That's very important. We fear referral because we think we will lose the patient. The patient may not come back. But there are standard procedure or standard clinical guidelines when to refer, and that should be followed to the T. Continuous education is extremely important. If you look at the patient management strategies, annual eye checkups, or as advised by the ophthalmologist, patient empowerment, yes, you need to educate the patient and make them aware that this is where the risk lies, so that they can also participate in helping you managing their clinical condition better. It is always crucial to address the socio-economic factors and healthcare disparities, and telemedicine solution has come a long way because AI is helping us with the use of cameras that you can detect anywhere, wherever the patient might be, you can able to detect their retinopathy sitting in a tertiary care center. So technological advancement definitely is technology is AI integration into screening, advanced laser technology, drug delivery innovations, and mobile health applications all can help you. And presently these are very much in vogue, so we do not fear of using these modalities in order to help the patients. So future treatment definitely is personalized treatment, improving access, holistic approach has to be the key, be it for this retinopathy or with any people living with diabetes. A holistic approach is become mandatory. We are no more just about controlling the sugar, but definitely sugar control is extremely important to bring out the risk of diabetic retinopathy. So friends, that was the preventive strategies which one need to adopt. So looking to the treatment aspect, which is actually not a part of this particular talk, but what is important is optimize the glycemic control, optimize the blood pressure, optimize the serum lipids, and then use the adequate modalities in order. If there is a chance of tertiary prevention, you should use whatever modalities. Obviously, that's not in your hand. It is the hand of the ophthalmic surgeons who will help you out. And these are the various modalities, whether it is the pen, photocoagulation, intravenous injections, and all those. I think a lot of things were already spoken by Dr. Ashutosh Mishra about the biomarkers and by Dr. Tripathi about the various other modalities which can be used early in order to detect the CCF is one of such modalities which can at least give us an idea about the retinopathy and also the peripheral neuropathy. So say corneal confocal microscopy can give you an idea of peripheral neuropathy. So even that is so important that because that becomes relevant to the eye as well. So most important is you need to overcome the treatment barriers, and if that is reached, that can be reached to the collaborative care models. So you have to have integrated care pathways. The research we have to build up, because where we are presently and what should be our priority level, that should be taken into consideration. So research addressing these gaps is extremely important, and that is prevalent worldwide as well. But yes, in our part of the universe, we should be more vigilant about it. Patient education is the key. Shared decision making in any management way for any people living with diabetes is extremely important. The future is simply you have to look into various aspects which probably are the pointers to precision medicine. I'm not going to speak too much on that because two of my esteemed speakers have spoken a lot about those, the various biomarkers, the various other technology which probably will help us to go more closer to precision medicine and help in managing and preventing the various lesion prevention strategies. Thank you.
Wonderful lecture, Dr. Patni, and this was actually very practical because so much of retinopathy and microvascular complications. So any questions from the audience?
This is the last talk. Yeah, but we can expect questions. Yes, sir.
Dr. Patni, for a good deliberation on diabetic retinopathy, we as consultant physicians often face this problem. I think the cornerstone of therapy while preventing diabetic retinopathy is this, that proper management of the sugars and proper counseling and proper lifestyle modification. And particularly in those category of patients who are not compliant, and most of the patients are not adherent and not compliant, I think the trick lies in primordial prevention than going for the tertiary prevention and the care. I think if we can hit them fast and hit them hard, I think that is the main cornerstone of therapy.
Thank you for your input. And I think we need to end this. And a big round of applause for the audience. I think they have been there since morning, and now we want Dr. M.S. Agarwal to come on stage. So presently the CME credit point certificates has got exhausted. But then who have attended the session for 2 days, they can still give their names to the registration desk. We will provide them the certificate. So there is no issue there. Right? So now we are going to the last part, that's a valedictory. I'll ask Dr. M.S. Agarwal, Dr. Thomas Bhattacharya, Dr. Benedict to come on stage. And I will also ask Dr. Brij Mohan sir, Dr. K.K. Tripathi, Dr. Ashutosh Mishra, Dr. Vinod Mittal sir to come on stage as well, because, yeah, please do come.
Linda Churtulli Tuti? No.
And requesting all who are there outside the hall to come in. We will be having a group photo. Please do not leave. Lunch will be served in 3:30. Subhas, you did not stay sit there. Dr. Bhavtarini ma'am, why are you sitting so quiet?
Would like, and I would like to thank our sponsors. For that, I asked Dr. Patrick to come onto the stage and give the vote of thanks to all those who tried us, who have supported our efforts and our endeavor to do this scientific session.
Good afternoon, ladies and gentlemen. Thank you for staying there. We had a great academic feast for the last 2 days. Our organization, BFW, every year tries to do this academic feast in an excellent and extravagant manner. We have always a galaxy of national speakers and local speakers attending and giving their deliberation. So at the end of the day, it's a thanksgiving ceremony basically. So Dr. Patni will make 2 important decisions, 2 important announcements, and just one clarification I want to give that regarding the exhaustion of the WBMC certificate. As because they have given only a certain number of certificates, those who have registered there and signed for 2 days definitely will get the certificate. Please bear with us, write your name and you will be provided the certificate. So Dr. Patni will make 2 important announcements. Patni sir.
Now the 2 contests which was on, one was on clinical cases. And I'm very happy to say the best presentation was by Dr. Pinaki De. If he's here, please come on the stage. Oh, thank you, Dr. Pinaki De. His was the best presentation, and the judges were Dr. Smita Bhatt and Dr. Mukhya Prana Prabhu, both from Animal Hospital. And the next is the best poster presentation. I hope they are around. So the best poster presentation was by Dr. Kunal Agarwal. Is he there? Yeah, come. Kunal, I think, is from KGM? No? Manipal. He is again from Manipal. Oh, big round of applause for Kunal. Second is Dr. Yogita and rather there is a tie between Dr. Yogita and Dr. Moshmi Ganguly. Are they there? Dr. Yogita and Dr. Moshmi Ganguly. Okay, but let me tell you, all the presentation, all the posters were absolutely great. And I thank Dr. Jyoti Pachishia, Dr. Seena, Dr. Seoni, Dr. Shobi, all of them to contributing to the poster presentation. Thank you all of you. And Kunal is here and Dr. Pinaki is here. And I will request Dr. Sarvavala to give a small token of gift to both of them. Can you come on stage here, please? I'll request Dr. Kamlakar Tripathi sir and Dr. Brijmohan sir to do the
in your fifth from Kolkata.
Sir, it is good.
A big round of applause, please. And I'll again hand it over to Dr. Partho.
So continuing with the thanksgiving ceremony, any academic program, any academic piece cannot be completed without the help of our academic partners.
on behalf of the organizing committee here at WA Kolkata, I thank Novo Nordics, Sun Pharma, Torrent Pharmaceuticals, USB, Novartis, VI, Bayer, Corona, Medioplex, Shine Pharma, Corona Remedies, Cipla, Aries, MQ, JB Pharmaceuticals for their extraordinary support which they have provided us to host such an excellent academic event. Special thanks goes to Mr. Ritam Jana of Grey Note. He has been extremely helpful since the first days and have been till helping us till the end. Now, for Vishwabanga Center, we extend our gratitude to Mr. Shagurika Banerjee and team for hospitality and for hosting us. Zone by the Park, led by Mr. Ramanpreet, Mr. Shourab, assisted by Mr. Amit Pathik and Shubhodip and their team. They have done an extraordinary job. The audiovisual team also needs a round of applause, led by Buddha Nanda. And the photography by Mr. Trilok Banerjee. So, our thanks to all the faculties who have come from all the parts of India to grace this occasion and all the delegates who have attended till the valedictory session. Thank you. All are requested to please come on the stage. All are requested to please come on the stage. We will be having a group photo. This will be a priceless memento for all of us. Please do come on the stage.
সামনে একটারও বসে যাবো
এটা দেবো না শরীরটা খুব ভালো হ্যাঁ হ্যাঁ করে নে 2 মিনিট দেন না 2 মিনিট দেন ভালো হবে 2 মিনিট করে না তাড়াতাড়ি স্যার একটু চেপে স্যার চলো মারো মারো হ্যাঁ এই বিন্দা মারো সবাই সামনে ওই চেয়ারটা সরে গেল ওই চেয়ারটা অপারেশন করতে বাইরে ওই পাশ থেকে একটু তুলে দাও না পড়ে হ্যাঁ তাহলে দেখতে ভালো লাগবে ব্যানারের মধ্যে থাকি সবাই সামনে স্যার একটু চেপে দাঁড়াবেন সবাই সামনে সবাই লেন্সে দেখাবেন
এই বাদিক থেকে এতখানি বের করে এলাম আবার এলাম তারপর আবার বেরিয়ে
বাইরে চলে এসছে সবাই
বুঝছো তো
হ্যাঁ
এত অ্যারেঞ্জ করে আমি একটা